Anybody know what this is on this little crab fork? Is it a tumor? It's a good guess. It's probably a tumor. Why is it so pretty? They plastered it. So a surgeon painted this. This is margin inking. So when you, as a clinician or a surgeon, remove a tumor and you want to know that cranial margin was pretty close. I'm not sure I got it all at the cranial margin. As soon as you dump this thing in a jar, all tissue orientation is lost for me. I get a little piece of dog in a jar. I don't know I can tell up and down, right? I can tell this is skin and this is dermis, right? But I can't tell which end was which on the dog. So if you need me to know that information for you clinically, you have to mark the margins for me. Be like, green is cranial, blue is deep, orange is whatever. And then I'll be like, oh, okay, well, the green margin has tumor cells at it and it's dirty, but the blue margin looks good. Yeah.
How does this not wash off?
It's magic. It's magic biopsy tissue ink. It does kind of come off, like I can tell when I have an ink sample to cut because the jar of formalin is like dark blue, green, brown. Okay, so diagnosis of neoplasia. This is a hint. We're going to do a lot of tiny tissues on crab forks. Okay, so clinical diagnosis of neoplasia. Imaging, remember that a tumor has to be a certain physical size to be detected on imaging. So that's about a cubic centimeter. Or it needs to be causing distortion of an organ, enlargement of an organ, some kind of thing big enough to see on imaging. So pros of imaging, it's relatively sensitive. That's a fairly small mass. I will tell you that this is not as sensitive as some crazy cat ladies who have sent me masses that are like a millimeter or two. I'm like, how did you even find this? It's like a speck. Cons of imaging, it can be really difficult to differentiate. Is this neoplastic or is it chronic inflammation, right? I can tell there's nodules, masses. I can tell they're destructive, but that can describe either neoplasia or granulomatous disease. It's also difficult to tell if we're dealing with something benign or malignant unless there's clear evidence of metastasis or very clear evidence of invasion, which invasion is often more difficult to tell on imaging. Metastasis, you should see. See metastasis, you can call it cytology. So this is where we found a lump. The lump has to be at least this big for us to have detected it. We're going to stick a needle in it. We're going to suck out some cells, squirt them on a slide. This usually can tell neoplasia from chronic inflammation, right? So I can tell if there's activated macrophages, lymphocytes, necrosis, neutrophils versus tumor cells, right? So it's pretty good at, is this cancer or inflammation? It's not always great at benign versus malignant. So I can tell you if it's cancer or not. I might be able to tell you my feelings on, I think it's potentially malignant or potentially benign, but this is difficult for cytology. It is most sensitive for round cell tumors, so they're going to exfoliate a lot. We're going to see them. Good for diagnosing round cell tumors. For a lot of other tumors, it's not very specific. It's relatively sensitive for neoplasia, right? I can say neoplasia, yes, no. It's not specific. I can't tell you what type of tumor it is.
Presence of neoplastic cells cause an inflammatory response, but when you look at cytology, you also see.
It depends on the tumor type. Remember, if you are a neoplastic cell, your goal is to not be detected by an immune response. So I would say a majority of neoplasms are not highly inflammatory unless there's the necrosis, and then the necrosis is inflammatory. There are a handful of tumors that are very inflammatory. So we're going to talk about immune response tumors a little bit, and I've got some examples if you would be. Melanoma is one that's often very inflammatory. You can also have tumors that are highly inflammatory because of something they're producing or how invasive they are. So for example, when I see a squamous cell carcinoma, keratin is really inflammatory. It's foreign material. So there's often a pyogranulaminous response to a squamous cell carcinoma because of the release of keratin. That makes sense. So it depends on the tumor. All right, biopsy. Now we're to the good stuff, the stuff that's actually gonna give you answers to what this tumor is, benign or malignant, and if you got it all. What more could you wanna know? So remember, a biopsy is ante-mortem. There are two types. It's either incisional, where I want a diagnosis, I need to give you a little piece, but I'm not gonna take out the whole thing. Maybe it's really big. Maybe you wanna know what it is, so you wanna know how big of margins you need to take before you take it off, so surgical planning. And then excisional, the goal is to completely remove it with clean margins, meaning everywhere I look at these inked margins, there are no tumor cells. You got it all. All the tumor is confined to the middle of this thing. Okay, and then I'm gonna take this, I'm gonna make it into slides, I'm gonna look under the microscope for those criteria of malignancy that we talked about. How well differentiated are these cells? Can I tell what cell this used to be? Can I tell who the tumor is coming from? How mitotically active is it? Are the mitotic figures really weird looking, or are they normal? There's just a few of them. How bizarre are the nuclei? And then most importantly, do I see metastasis under a microscope in a tumor? To me, metastasis looks like emboli of tumor in a lymphatic vessel or a blood vessel. That to me is, this is 100% malignant. I can hang my hat on that because that's the definition of metastasis. Also, if I see local invasion, I'm going to call that malignant. And then again, if the orientation of this thing is important to you, you, the clinician, need to ink that for me and tell me what ink is what side, right? So you need to put on the ink and then you need to tell me blue is the deep margin, orange is the proximal margin, orient me on the tissue, right? Here's what that looks like on histopath. The ink actually sticks pretty well to the surface. So here's the green margin, and this is all fat and a little duct. So this looks free of neoplastic cells to me. This is a clean margin. Any questions?
How frequently are you getting incisional biopsies? Because it seems to me like in VIII, like if we're gonna go to the trouble of taking something off, we have to take full.
Some things are too big
Okay.
to take off. Some things are gonna bad location and hard to take off, like in pose or on a distal limb. So sometimes they will excise it, but they'll only send me a piece because it's big, right? So I will get an incisional biopsy. I don't know if they excised it or not. They're just sending me, like, we call them rep sections, like a representative section of the tumor. All the tumor looks like this, so I'm just gonna send you a little piece because it's a basketball, and that would cost me a lot in shipping. Yeah,
Are there situations where like biopsies will make the tumor get green, like, and have more effects in like certain tumors than
Definitely.
biopsy?
oh. There are certain tumors you shouldn't biopsy in certain ways. So you don't want to, if you have a suspicion of a transitional cell carcinoma in a urinary bladder. What might be a way you don't want to biopsy that tumor because you're worried about taking the tumor and seeding it other places? What? Cysto. I don't want to do a cysto if I suspect a TCC because I'm going to seed my needle tract with carcinoma. I might be seeding the belly with carcinoma. I might be predisposing to carcinomatosis. What would be a good way to biopsy a TCC that avoids that? Cystotomy. So go up there and get it. Catch some urine, free catch urine, just see if there's tumor cells in the pee exfoliating. So you do have to be careful with certain types, but that's a much more clinical question.
Would you be cautious of a urinary catheter for the same reason?
So traumatic catheterization is also a way of collecting a biopsy specimen from bladder. You've got a catheter, you just kind of like scrape it around a little bit to get more cells to exfoliate. I know
You're
that's.
not worried about bringing the seed, I mean, I guess.
I don't know, that's too clinical for me to answer. Right, they're gonna do it anyway, probably. Okay. So we left off talking about diagnosis of neoplasia. Big take home from the crab fork image, you guys mark the margins for me, not me. I tell you if they're clean or dirty, but you need to tell me where they are in the body, because when you send me a chunk, can't tell it. We get a lot of clients that send us unlabeled tissue, meaning it's not ink, there's no suture on it, there's no indication of where it is on the body, and they ask me for a margin study. and I can't do that. They're ordering a test that I can't give them because they haven't given me the information. Does that make sense? So people don't seem to know that this is their job in surgery. After you take it out, put ink on it, then it goes in the jar. That's me. Biopsies can be incisional, excisional, depends on your goal. Sometimes a mass might be really big, a place we can't really get complete margins on easily. So like on the face, head, on a distal limb, places where there's not a lot of soft tissue to work with. We can also do excisional, meaning we're trying to excise the mass. The goal is complete or clean margins. What I mean by complete or clean margins is that there is no tumor at the margins. They're clean. They're free of neoplastic cells under the microscope. Depending on the tumor type and what it looks like, if it's really poorly differentiated, I'm not going to be able to tell what it is just by looking at it under the microscope. I'm going to need more help. Sometimes I can't even tell which germline it is, epithelial, mesenchymal, round. Tumors can look really crazy. They don't look like anything. They're so stem celly that I don't even know what cell they came from. So it may not be easy to identify the cell type or even the germline of origin in these tumors that are really poorly differentiated, i.e. very malignant. Poor differentiation goes with malignancy. So we talked about epithelial to mesenchymal transition. This actually changes the morphology of the cells. So a carcinoma under the microscope will start to look more like a sarcoma. The cells will be individualized, they'll be spindle shaped, they won't look or act like epithelial cells. So it might be really hard for me to tell under the microscope if I'm dealing with a carcinoma or a sarcoma. And prognostically, those are two very different things. Sarcomas are usually locally invasive but don't metastasize. Carcinomas often do metastasize. So in these cases where I can't really tell what's going on just by looking at it, we need immunohistochemistry or IHC. So this is basically an ELISA on a slide. We're doing antibody staining of the tumor to look for specific tumor antigens, so antigens that are only present on neoplastic cells. More commonly, we're looking for shared markers, so I can do cytokeratin, for example, will stain all epithelium. So if I put a cytokeratin on this thing that has really bad epithelial to mesenchymal transition and it's positive, that tells me, okay, this is a carcinoma and not a sarcoma because it's staining for an epithelial marker. There's also specific markers. There are specific cytokeratins. There's a bunch of numbers. They're like 1 through, I don't even know how many there are. Certain cytokeratins will only label specific epithelium. So there's a cytokeratin that I can use if I want to identify squamous epithelium. So it'll stain a squamous cell carcinoma and it'll stain normal epidermis, but it won't stain like an adenocarcinoma, for example. So there's a lot of different markers we can use. Some are tumor specific, some are specific to a germline, some are specific to a specific cell of origin. Does that make sense? So basically an ELISA, does everybody know how an ELISA works? Kind of mostly it's like an antibody sandwich. So antigen, we stain it with an antibody to our antigen of interest. We then use a secondary antibody so we can see the first antibody, and the second antibody has some kind of, it's called a chromogen on it, something that turns color so we can see it. Usually it's brown or red with, histochemistry, like our ugly, dirty brown colors. So here's an example of what that looks like. We've done, I don't know what IHCs these are. These are all staining for different markers. Remember, these are cellular antigens, so they can be anywhere. Some of them are in the nucleus, some of them are in the cytoplasm, some of them are in the membrane, and that kind of helps us tell how well the stain is working. Is it staining what I'm needing to stain? For example, if I use a stain that I know is looking for a cytoplasmic marker, like a cytokeratin, a filament that's in the cytoplasm, or vimentin, another filament, and I get my stain back and it looks like this, that stain has failed. Like, this is incorrect. It's not labeling the thing that I expected to be labeling, so I'm gonna have to go back. But this can give us a lot of additional information that we can't see under just a light microscope, on just an HV with the pinks and purples. These cost extra money, sorry. All right, so grading and staging. These are our attempts to predict how the tumor is going to behave clinically, biologically in the patient, and the prognosis for the patient based on the specific tumor type. These are really important to do usually early on after a tumor is found because they can inform the treatment strategy or even the owner's decision to treat. If I have a tumor that's highly advanced, very aggressive, and has a poor prognosis, we may not do heroics for that animal. If I have something like an indolent lymphoma, what indolent means? Indolent means like, so how do I describe it? It's kind of like subclinical, like lymphoma is always malignant, right? But an indolent lymphoma is one that's not very aggressive, so it just kind of like smolders along. That's what indolent means, not very bad. Right? Probably better definitions on the internet, that's the best I can do right now. So if we have something like an indolent lymphoma, something that is not very aggressive, something that's slowly progressive, and something that's highly amenable to treatment, has a good prognosis, we're probably gonna treat that thing. So these are really important information early on to have. Grading is done by me, the pathologist, so grading is based on the histopathology. What does it look like under the microscope? How mitotically active is it? How fast is it dividing? What is the shape, size, degree of differentiation, how anaplastic, how poorly differentiated, how pleomorphic, multiple morphic morphologies. So if there's multiple morphologies in the same tumor, that's an indicator of malignancy. Necrosis in the tumor, stuff like that. So for grading, these are usually published schemes. You can find them in the literature. And they're based on specific tumor types. So in my office, I have basically a printout of grading cheat sheets. So if I say, okay, I have diagnosed this dog with a soft tissue sarcoma, I then go to the soft tissue sarcoma grading scheme and I say, it's basically like those like teenage girl magazine quizzes. Like if you score this, it's a 1, and if you score this, it's a 2, and you add up your score at the end and see if the tumor loves you or not. So for soft tissue sarcoma, for example, the scheme is, the criteria are how many mitotic figures are in it. If it's a low number, it's a low grade, or it's not benign, they're all malignant, but it's less aggressive. If it has a lot of mitotic activity, it's more likely to be fast growing, it's a high grade. High grade bad, low grade good. Degree of differentiation is the other criteria for soft tissue sarcomas. You guys do not need to know this at all. This is me stuff. I'm just giving you an example of what we're doing behind the scenes. How well differentiated is it? So I can tell it's a sarcoma, so I know it's mesenchymal, but can I tell if it's a fibrosarcoma versus an osteosarcoma? If I can, that's good differentiation. That's a low grade. If it's poorly differentiated and I can say it's a sarcoma, it's malignant mesenchymal, but I can't do better than that, then it's high grade. And then necrosis, which is another measure of how fast it's growing. So for a soft tissue sarcoma, those are the 3. For a mammary carcinoma in a dog, they're totally different grading scheme. So it depends on the tumor type. Staging is done by you guys, either the clinician or often an oncologist. And that's based on clinical information about the tumor. So TNM is the acronym. We're doing physical exam, we're doing imaging. Tumor is how big is the primary mass, and where is it? N is nodes, so has there been spread to regional lymph nodes? And M is metastasis, so has it left the primary tumor and gone to distant sites? So this is, what is it doing in the body? Is staging. Grading is, what does it look like on the slide? One is a pathologist, one is a clinician. Does that make sense? All right, so we've been doing this kind of a lot. I'm not really gonna talk about it, but does anybody have any questions on this from practicing in Bioplasty? Usually start with, is it primary or metastatic? So for that, am I seeing an embolic pattern? Is it one mass or a bunch of masses? If I decide it's primary, who lives here? Who is in this normal tissue that could become neoplastic? When I'm thinking about these choices, I usually rank them by like percent of tissue that is that cell. So when I'm thinking about a liver, I'm thinking about hepatocytes mostly. And then who is next after hepatocytes? What's like the second most popular cell in the liver? Yeah, biliary epithelium. So when I think about a liver, my top two, the bulk of the parenchyma of the liver is made of epithelial cells. I think epithelial tumors are gonna be most common in the liver. Does that make sense? So decide on the germline and then use the organ and the tissue type to come up with differentials for the cell type of origin. Benign or malignant, we've talked about this a lot. What does it look like? How is it growing? How is it interacting with tissue? Has it metastasized or invaded?